My name is Darren Kies. I am the Section Chief of Interventional Radiology for Piedmont South Imaging. A radiation segmentectomy is a term that's come into use that is used to describe the very focal, either 1 to 2 segmental distribution of Y90 into the liver for the treatment of a malignancy. And you use a very high dose of radiation. So the way this was kind of came about was that in this originally was done using glass microspheres, but you can also use resin microspheres. But folks noticed that if you deliver a very focal high dose of radiation to a certain segment of the liver that contains a tumor, not only can you get excellent tumor control and you can kill a tumor, but on follow-up imaging, you literally get a wedge-shaped area of just kind of parenchymal necrosis that happens of the normal liver around it. And the appearance of it almost looks like a surgical segmentectomy. The way that this was originally performed was you would calculate the correct dose for a whole right lobe of the liver. And then say you have a tumor with a single feeding vessel in segment 8 of the liver. You would take that lobar dose and you would deliver it directly into segment 8 of the liver, which would give a very, very, very high dose of radiation to that segment. Dose estimate studies range at anywhere from 2 to 300 gray. And this again is designed to deliver an ablative dose of radiation to a focal segment of the liver. And that kills the tumor and it kills most of the normal tissue in that segment. And the advantages of performing Y90 in this fashion is it truly is an ablative dose of radiation, and the outcomes for this type of Y90 delivery are more akin to a thermal ablation than they are to the lobar treatment of, say, multifocal metastatic disease. So really, it should be thought of as almost an ablative type therapy as opposed to a palliative type therapy with local control rates that approach things like percutaneous ablation. Now, the advantages of having that in your toolbox as an interventional radiologist is that it's not quite as good as ablation. I don't want to confuse anyone. An ablation is still slightly better local control when it comes to the treatment of primary tumors, but a radiation segmentectomy is a close second. And the advantages of it is that there aren't any geographic regions of the liver generally that you can't treat with a segmentectomy. Some vessels can be difficult to catheterize, but for example, you can perform a segmentectomy to a lesion that's right up against the gallbladder or right up against the diaphragm or right up against the liver capsule in scenarios where maybe you would not want to perform an ablation because of the risk to surrounding structures or pain after the procedure, or if the lesion's right in the center of the liver where you can't safely perform a percutaneous ablation. And this can be performed with either glass or resin microspheres. Some folks have started to use anti-reflux catheters or balloon occlusion catheters to even drive the dose closer in to the liver. Also, the dosimetry has become more sophisticated in that now we've learned through studies that you need to at least cross a threshold of about 190 gray for whatever segment you're going to treat. So nowadays, instead of just calculating a right lobar dose and doing a little hand waving about the actual dose that the segment is going to achieve, you can specifically calculate a dose for 190 to 200 gray for your certain volume of liver and deliver it safely with effective oncologic outcomes.